Hi all, due to being short staffed, I'm asked to provide a ward cover, and guess what? I'm in the COVID ward. So I'm just going to go to the COVID ward and do some pharmacy clinical verification. Get you there. Receive a query from a doctor about hypocalcemia. The calcium level was adjusted calcium level was 2.04. So suggested to check if the patient was hypocalcemic symptomatic. And we've also suggested to see if you've done the magnesium levels and also vitamin D levels to be able to get a clear picture, and also checked if the levels, low levels, were acutely low or chronically low. So we had the previous bloods and it was acutely low, and obviously in chronic condition we can also check the parathyroid hormones as well. So this was one, and they've asked us to suggest any treatment plan for hypocalcemia. So normally, obviously, if we have the levels done, we will just top it up with normal calcium oral tablets. You don't have to go by IV route unless it's below 1.9 as per the guidelines, and if it's below 1.9 and unless it's symptomatic, we monitor ECG and prescribe calcium gluconate 10%, 10 ml, and mix it with 100 ml of normal saline or dextrose, and that's what we'll do and give over 10 to 20 minutes in an IV setting. So it all depends upon the clinical picture of whether or not the patient is symptomatic, and the levels are, even if it's over 2 adjusted calcium, and if it's symptomatic we'll monitor ECG and give IV. If it's not, then we'll wait to see if it's below 1.9, and in this case obviously the patient is not symptomatic, so what we'll do is we'll just prescribe oral calcium replacement. Another patient had a potassium 3.4, and it was prescribed Sandoke 2 tablets twice a day yesterday, and we've checked the levels. Obviously we've already given over 2 doses. Normally we don't start replacement unless the patient is symptomatic, again with hypokalemia symptoms. Only then we start Sandoke tablets. In the same patient, the CRP was 85 and the white cell count was normally in range, and it was a chest infection, pneumonia-like symptoms. They've given IV comoxiclav, so I've suggested to change it to oral comoxiclav in view of the inflammatory markers. Obviously we don't need to give IV unless we really need to, and the inflammatory markers show that they are really high and it would require intravenous treatment. So we manage it on oral. So this is what I suggest. Just had a discussion with a consultant about the antibiotic prescribing for cellulitis. The patient was prescribed flucloxacillin initially for a couple of days, and then they've added amoxicillin. So there was no rationale, and a day dose was given, and then obviously I reviewed the drug chart and realized these two are given in combination. And because the consultant said he wanted to give it, sometimes that's not the reason. They'll have to come up with some sort of facts and figures to be able to talk to the consultant and the doctors in terms of the coverage that's been given by the antibiotics, and whether or not it's suitable, whether there's evidence for it, what the guidelines say, the national guidelines say, the trust guidelines. So obviously if it's not written in one of those, obviously sometimes you have to have a discussion about it, and then the discussion was productive, and he was happy to remove amoxicillin and confirm to carry on with flucloxacillin. So this was one. It was another patient treated for sepsis, and was prescribed IV metronidazole and piperacillin tazobactam combination antibiotics. So these two were prescribed in view of 25 white cell count and also over 200 CRP. The patient presented some symptoms of UTI, so an addition of nitrofurantoin oral tablets was done. Just a discussion again with the doctors about it, and the PIP-TAZ covers, because of very broad spectrum antibiotic, it should cover the UTI, and they agreed and removed nitrofurantoin. So these deprescribing is part of our role as pharmacists on the wards. This is what we do.